Thank you, Dr. Gandhi.
Pleasure to be here. Before I get started, can I ask if you see my screen okay? I'm getting a thumbs up. Good. Thumbs up back to you. Thanks to the conference organizers for inviting me to speak. I'm going to talk about what I call the multidimensional challenge of COVID-19. You'll see in a moment why. And I'll include a section on COVID-19 and HIV. Here are my disclosures. And here are our learning objectives. We'll walk through the clinical manifestations of COVID-19. We'll talk about treatment, and then we'll talk about COVID-19 in people with HIV. So this is what I term the multidimensional challenge of treating COVID-19. I really think about three things when I think about treating this disease. I think about the host and the clinical manifestations, as well as the risk factors for severe disease. I think about the stage and severity of the infection. Is it early? Is it late? Is it mild, moderate, severe, or critical? And then I think about the intervention itself. Is it an antiviral, an immunomodulator? Are we giving combinations, or are we treating the complications of COVID-19, for example, with anticoagulation or with ventilatory support? So let's go through some of the main clinical manifestations of COVID-19. Classic symptoms include fever, cough, sore throat, malaise, and myalgias. As I think is well known by now, gastrointestinal symptoms may occur, things like anorexia, nausea, and diarrhea. Patients may complain of taste and smell disturbances. And really what portends worsening is the development of shortness of breath. Most people will have mild disease, but if they develop shortness of breath, that can be an early harbinger of clinical worsening. And that occurs at a median of somewhere between 5 to 8 days after symptom onset. For severe COVID-19, patients can have lymphopenia. They can have elevated levels of a variety of inflammatory and coagulation markers, as well as liver enzymes. Now, some of the classic radiographic features of COVID-19 are shown here. People can have peripheral bilateral ground glass opacities with or without consolidation. I think you can see that very nicely in this particular CT scan. And sometimes those ground glass opacities may have, as you see here, a really distinctive rounded morphology. So this is a classic CT scan of COVID-19. Now, although COVID-19 starts out as a respiratory illness in many individuals, it really can affect almost every single organ system in the body. So the respiratory symptoms we've touched on, things like dyspnea and cough, pulmonary infiltrates, etc. But from there, it can really cause a variety of different manifestations. So there can be neurologic complications, including stroke. There can be cardiovascular complications, including myocarditis, arrhythmias, even myocardial infarction, renal failure, a variety of gastrointestinal manifestations, including nausea and diarrhea. There can be skin manifestations. I'll show you in a moment the famous COVID toes, but there can be other manifestations, cutaneous manifestations as well. And then people can have a variety of systemic complications, and we'll touch on those when we talk about the hyperinflammatory state of COVID-19. So this is what you've undoubtedly heard of, the COVID toes. These are known as pernio or pseudo-chilblains. What they consist of are these erythematous to violaceous macules, sometimes papules or papulonodules. And you can occasionally get what looks like pseudovesiculation at the tips of the digits and the soles of the feet. These manifestations can sometimes occur late in the course of COVID-19, and there's still a lot more that needs to be learned about why this happens. The cardiac manifestations can be particularly pronounced, especially in severe COVID-19. People can have acute cardiac injury manifested by elevated troponins. We've seen patients, including some young patients, presenting with heart failure and cardiogenic shock. Some of them have a myocarditis-like syndrome. People can have arrhythmias, and they can even have thrombosis, and we'll touch on that in just a moment. So I learned something when I started learning about COVID-19, which is something called thromboinflammation. Earlier on, data from China shown in this figure associated elevated inflammatory, but also coagulation biomarkers with more severe disease and mortality. So if you take your eyes over to the right, you'll see that the people who were non-survivors, people who died of COVID-19, tended to have much higher D-dimer levels, which is a coagulation marker, much higher levels of interleukin-6, much higher levels of troponin than those people who survived COVID-19. This inflammatory response, as well as this hypercoagulable response, may lead to endothelial injury and can cause a coagulopathy. And some of the complications we and others have seen in COVID-19 include pulmonary emboli, myocardial infarction, and in the most severe cases, disseminated intravascular coagulation, or DIC. Now, this was really brought home to me by this autopsy study. This was published in the New England Journal just a few months ago. In this particular study, they looked at the lungs of people who died of COVID-19 and compared the pathology to lungs of people who had influenza-related acute respiratory distress syndrome, or the lungs of people who died of unrelated causes, non-infectious causes. And what they showed in this particular autopsy study is that the COVID-19 lungs showed features of endothelial injury, widespread thrombosis. Some people had these microthrombi that you can see on the right-hand side of the screen. People had alveolar capillary microthrombi, and then something distinctive called the intussusceptive angiogenesis. So bottom line is people with COVID-19 in the lungs are showing evidence of endothelial injury as well as this thrombosis syndrome. And we believe that that's linked to this idea of this manifestation of thromboinflammation in severe COVID-19. So what are the risk factors for severe COVID-19? So many of these are well known to you by now. Older age, in every series that has looked at this, has been associated with severe COVID-19. Chronic obstructive pulmonary disease, and in a study from the UK, severe asthma was linked to severe COVID-19. Cardiovascular disease, diabetes, obesity has been shown time and time again to be linked. Other risk factors include sickle cell disease, chronic kidney disease, and immunocompromised states from solid organ transplant. This is from a recent CDC website, and there are reasonable data for all of these. What's a bit more uncertain are the role of pregnancy. There are some data supporting this, but still more needs to be learned. And then other immunocompromised states is still uncertain. And when we get to HIV, we'll talk about that in much more depth. One thing that is also clear is that there's a disproportionate burden of COVID-19 among racial and ethnic minorities, Native Americans, and the poor. And we'll return to that again when we talk about HIV. So this is how I like to frame the treatment kind of approach. So I think it depends on where you are in terms of stage and severity, and that lines up a little bit with what we understand with disease pathogenesis. So asymptomatic or pre-symptomatic COVID-19 means you've got a positive COVID-2 test, but you don't have symptoms. 80% of people who develop symptoms will have either mild or moderate disease. So mild disease is usually fever, cough, taste and smell changes, but no shortness of breath. Moderate disease means that you're now developing some signs of lower respiratory tract disease, sometimes with shortness of breath, but you don't have hypoxemia. Severe disease, at least in data out of China early on, occurred in about 15% of people, and that's when you've got hypoxemia, tachypnea, and lung infiltrates that are quite prominent. And that critical illness is really that 5% of people who develop respiratory failure, shock, and multi-organ failure. Now, we think that viral replication of the COVID-2 virus predominates early on in mild and moderate disease, and then tapers off as people get further along in the course of their infection. And we think that hyperinflammation or overexuberant immune response is responsible for some of the manifestations of severe disease that I've touched on already, as well as critical disease. And when we get to the interventions, it will become clear why it's important to know the stage of disease. So antivirals, and we'll give you an example of this, are probably likely to be most effective in the earlier stages of disease. Antibody therapies are probably in that same category. And then anti-inflammatories, and there are data now for this, are probably going to be most important later in the course of disease. So let's give some examples. We'll start with antivirals. So the antivirals that are either in trials or have been studied really can target different parts of the virus life cycle. So virus entry goes through a receptor called ACE2, and there's also a host, a protein called TMPRSS2, and a drug called Camostat really targets that part of the virus life cycle. The virus then has to go through membrane fusion and endocytosis. Hydroxychloroquine was thought to target that. There are less supportive data for that we'll review. The viral protease is purported to be inhibited by lopinavir ritonavir, although we'll get back to that. And then the drug that really has the most data behind it is remdesivir as an antiviral. And what that's doing is it's targeting the viral replication machinery, which is an RNA polymerase. So a word about hydroxychloroquine. All of us have gone through this process together. Early on in March and April, most of the data that we had came from single-arm studies as well as a variety of observational cohorts. But really starting in May into June and now into July and August, we have the results of randomized trials, which are really informative. So in the post-exposure prophylaxis setting, hydroxychloroquine was not found to be any better than placebo in terms of preventing progression to COVID-19 after exposure. There are some limitations to this particular trial, but certainly there was no difference in this trial between hydroxychloroquine and placebo. Early treatment also has been studied, so people just a few days after onset of symptoms, and again, no difference really between placebo and hydroxychloroquine in terms of symptom resolution or symptom improvement. And then finally, and I would say this is probably the most definitive trial in hospitalized patients, a large study done out of the UK looked at many thousands of people with COVID-19 in the hospital and really found no difference between hydroxychloroquine and what they call usual care in terms of mortality as well as other hard clinical endpoints. Let's now shift to remdesivir. Remdesivir is an antiviral. It's a nucleotide prodrug. It inhibits the viral RNA polymerase and it works as a chain terminator. In an animal model, and this is interesting, what it does is it reduces the SARS-CoV-2 levels in the lung, but not in the upper respiratory tract. It does ameliorate or decrease disease. Now, the human trial that really led to support for remdesivir is called ACT. It's an NIH-sponsored trial, and the preliminary analysis was published in May. What it showed is that the recovery, clinical recovery, was more rapid with remdesivir than with placebo by about 33%, so 11 days versus 15 days. Mortality was about 7% in the remdesivir group and at just under 12% in the placebo group. There was a strong trend, but not statistically significant. But what was clear is that the benefit of remdesivir was clearest in those who were on supplemental oxygen but were not yet critically ill, not yet intubated. And that accords with that paradigm that I was showing you earlier, which is antivirals working a bit earlier than anti-inflammatories. In a separate trial called SIMPLE, sponsored by the manufacturer of remdesivir, that showed that people with severe COVID-19, that 5 days of remdesivir was as good as 10 days, and that was done in people who were not yet intubated. Antibody therapy. Antibody therapy can be given in one of two ways. You can either transfer antibodies from people who've recovered from COVID-19. This is known as convalescent plasma. Or there are now monoclonal antibodies that have been isolated and really target the virus. One open-label randomized trial of convalescent plasma in China didn't show a benefit in the overall population that was studied, but it suggested there may be a benefit a bit earlier before you got to critical disease. But all of the patients in this particular study were treated quite late, a month into therapy, so it was not definitive. Over 20,000 people with COVID-19 in the US have received convalescent plasma, and transfusion reactions to date have been very, very low, and there's been a low rate of other complications. So what we can say is it seems to be a fairly safe intervention. As to whether convalescent plasma improves outcomes, we still need comparative trials to answer that question definitively. And thankfully, there are ongoing prophylactic and therapeutic trials, both of convalescent plasma as well as these targeted monoclonal antibodies. Steroids. Now, there has been controversy regarding the use of steroids in viral pneumonia for many, many years. And there's controversy about its use in acute respiratory distress syndrome. But because of that hyperinflammatory state that I mentioned earlier, steroids were evaluated as a potential intervention. And the trial that really showed that steroids had an impact, again, was the recovery trial out of the UK. I'll give a little bit more detail here. 2,100 people in the hospital were randomized to get dexamethasone. Over 4,300 people got usual care. And if you take your eyes over to the right-hand side to mortality, you'll see that there was a 17% reduction in mortality. The rate ratio for mortality was 0.83, quite statistically significant. But when you look at it carefully, most of the benefit was in those people who were on a ventilator or on ECMO. There, the rate ratio, there was a 35% reduction in mortality. If you were on supplemental oxygen alone, but not yet ventilated, it was about a 20% reduction. And here's an important point to make sure to focus on. If you were on no oxygen at all, you were earlier in the course, there was actually no benefit and there was a potential for harm. So the conclusion of recovery is that dexamethasone is associated with decreased mortality among those on supplemental oxygen or on mechanical ventilation, but no benefit in those not requiring oxygen, certainly not to be used in ambulatory patients. So coming back to our treatment paradigm, where I would put remdesivir is in that moderate to severe, probably early severe group, and then dexamethasone a bit later as you get further into the severe category and into the critical illness. Now, I started out this talk by saying most COVID-19 is mild, 80% or more, but a lot of the trials I've been showing you are focused on moderate or really severe or critical disease. And I think what you'll see is that the next wave of trials are really going to move over from the right-hand side of the slide, which are hospitalized patients, over to the left-hand part of the slide, which is earlier in the course of disease. Can we prevent progression? Can we prevent complications? Can we prevent death? And can we prevent transmission? And those are all really important questions that we hope to learn the answers to. Okay, so this is my summation before I go to HIV and COVID. COVID-19 prevention and treatment requires this multidimensional approach. You have to understand the host, the stage severity of disease, and the intervention. And depending on the host, stage severity, the therapy may actually differ, and I've given you an example of that. Antivirals will probably work earlier, immunomodulators will probably work later, and what we're now getting into is can you combine antivirals and immunomodulators? The other point I want to just bring home one more time is that there are really important lessons to learn from HIV. Just like in the early days of HIV, in COVID-19, there's been an immense pressure to deploy interventions, but we got to temper that desire to help people with our understanding that we got to find out if a treatment works, and our guide has to be the science. And just like with HIV, I know that COVID-19 will be an iterative process. We're going to get some advances and then build upon them until we get to a tipping point, as we did with HIV in 1996. So with that, let me do in the last few minutes just a brief update on COVID-19 and HIV, and I'll try to answer these three questions. Is HIV a risk factor for severe COVID-19? Do HIV medicines themselves have activity against SARS-CoV-2? And what is the impact of COVID-19 on HIV care and prevention? So here's a series of patients that we studied at Mass General between March 3rd and April 26th. We identified 36 people with HIV who also had COVID, and then another 11 who had probable COVID. A couple of take-home points from this. Nearly half of our patients either lived or worked in congregate settings, and that really highlights this particularly vulnerable population. The other major point is our study, like many others, found that 85% of our people with HIV who had COVID also had some other really important non-HIV comorbidity, whether it be obesity, cardiovascular disease, lung disease, etc. And I think it's probably going to be those comorbidities that determine outcome. The second major point from this study is that there is a disproportionate burden, not just among people without HIV, but among people with HIV of COVID-19. So 77% of people in our cohort who had HIV and COVID-19 were non-Hispanic Blacks or Latinx. And this is compared to our general HIV clinic population where Blacks and Latinx are about 40%. So really bringing home again this disproportionate burden. Now, what about HIV as a risk factor for COVID-19? This has been a concern since the very beginning, in part because other viruses like influenza are worse in people with HIV who have low CD4 counts. So the trial that suggests that there might be an impact comes out of South Africa. This is over 3.5 million active public sector adult patients, almost a little over 500,000 of whom have HIV. They had 22,000 cases of COVID-19, of whom 625 died. And in this particular study from South Africa, there was a greater proportion of COVID-19 mortality among people with HIV. It was about a twofold effect. But curiously, and this is still unexplained, it didn't seem to matter if they were virally suppressed and if they were immunosuppressed. And that really would come as a surprise. Now, I will say there is some concern that there may be some residual confounding in the South African study. They don't have data on socioeconomic status that can affect both. That can be an issue in HIV as well as in COVID-19, and they don't have data on obesity. Closer to home here in the US, this is a VA study, a rather large study of 30,000 people with HIV and 76,000 people without HIV. You can see the numbers of COVID cases in this VA cohort. And the bottom line from the VA cohort is that there was really no meaningful difference between hospitalization, ICU admission, or death by virtue of having or not having HIV. That is, the rates of all of these three important clinical outcomes were similar by HIV status. So this would argue that HIV is really not having a clinical impact on COVID-19. Just a couple of words on the HIV medicines themselves. So this has gotten a lot of press and a lot of attention. So we'll start off with lopinavir, ritonavir. Early on, I mentioned that SARS-CoV-2 has a protease, and at least in vitro, lopinavir, ritonavir can inhibit the protease, and that resulted in its being used off-label in people with COVID-19, not people with HIV and COVID, but just people with COVID. An early study done in China looked at 200 people, randomized them to get lopinavir, ritonavir, or a control group. And you can see in the graphic on your right, there was really no effect of the lopinavir, ritonavir on clinical improvement. More recently, that same recovery trial that I've mentioned before looked at 1,600 hospitalized patients who got lopinavir, ritonavir compared to 3,400 who did not. They haven't released all the data, but the headline from this kind of press release is that there was no impact on mortality, there was no impact of lopinavir, ritonavir on mechanical ventilation, and there was no impact on length of stay. So more to come, but really doesn't look like it's having an effect. Now, I in the breakout section on Sunday, I went into this, why I think lopinavir, ritonavir is not working. It turns out if you look at the levels of lopinavir, ritonavir that you need to get, you would have to swallow something like 60 to 120 pills of lopinavir, ritonavir to get high enough levels to inhibit the SARS-CoV-2 enzyme. So I think the bottom line is lopinavir, ritonavir works against HIV, but not against SARS-CoV-2 in a meaningful way. And so I think that's going to turn out to be true of the other protease inhibitors as well. Now, this study has gotten a lot of interest because it's looking at whether people with HIV, if there's any effect of their antiretroviral on COVID-19. So this was done in Spain. They had 77,000 people with HIV, and they had a little over 230 who were diagnosed with COVID-19. So what they did is they looked at whether there was any difference in hospitalization rate based on what antiretrovirals these people with HIV were getting. And kind of surprisingly, people who were on tenofovir disoproxil fumarate, TDF-FTC, had half the rate of hospitalization as those people who were on other nucleoside drugs. Now, remdesivir is a nucleoside, or it's a nucleotide, so are some of these drugs. So people began to wonder, could this be a signal that TDF-FTC might be having an impact? The reason why I think it's premature and why I've been telling my patients that I wouldn't draw too much from this is that they couldn't rule out residual confounding. People who are getting TDF-FTC might be a lot younger. They might have lower rates of renal disease than people who are getting other nucleosides, and those other things could be confounding this particular hospitalization rate signal. So I have not been shifting any of my patients off of their current antiretrovirals, and I think more to come, but I don't think we yet know that there's an impact of any of these antiretrovirals on COVID-19. I'll just give one slide on the impact of COVID-19 on HIV care and prevention. It's a summary slide from the recent AIDS 2020 meeting, and that was followed by a COVID-19 virtual conference. So the 3 points I'll make here before concluding is there was a WHO survey done not long ago that identified significant disruptions in access to HIV treatment because of COVID-19. Even more recently, there's data out of South Africa commenting on that. A second presentation at this meeting, it was a survey of over 13,500 LGBTI plus people in over 130 countries. Just as is the case in all the populations, there was increased socioeconomic vulnerability because of COVID-19, but perhaps even more concerningly, more than a quarter of people with HIV in the survey reported difficulty with accessing ART refills. And then last, here closer to home, at the Fenway Institute, Doug Krakauer and Ken Mayer and others looked at disruptions in PrEP care in the US, and they found substantial impact of COVID-19 on PrEP care, especially and concerningly among vulnerable subpopulations such as the young, non-white, Latinx, and publicly insured populations. So with that, I think I have 30 more seconds, so I will come up with my last thoughts and then open it up to comments and questions. So my first of my final thoughts, the disproportionate impact on racial and ethnic minorities of COVID-19 and of HIV highlight once again how disparities drive disparate infectious diseases. We've known this, unfortunately, for centuries, but it's really brought home to us again. And we must address the structural forces to end these intolerable inequities in healthcare access and outcomes for these, what I call twin epidemics. Second, we can't let the COVID-19 pandemic cause us to lose sight of how far we've come in our quest to end the HIV epidemic. I, like you, have been working on HIV for many, many years. And despite the overwhelming need that we all have to respond to COVID-19, we must continue to move forcefully to end the HIV epidemic here and around the world. So with that, I see my clock at 000, so I will stop, acknowledge a number of people who really contributed to this talk, and I'm happy to take any comments or questions.
Thank you so much, Dr. Gandhi. That was an excellent presentation. I really appreciate it. We do have a few questions from the audience so far, and I think they're continuing to come in. So I'll watch the time, but we do have plenty of time right now to go through those. So one question, in moderate, severe, or critical COVID cases, do you see a role for routine anticoagulation?
Yeah, that's a good question. So because of that thromboinflammation and because of rates of thrombosis and severe COVID-19, there has been a lot of interest in this question. And what I can say is the following. In critically ill patients, there is a really high rate of thromboembolism, PEs, pulmonary emboli. In some studies out of the Netherlands, it was really extraordinarily high. Now, in our own experience, we have about a 7% rate of thromboembolism among our severely ill patients, but there's also a 7% likelihood of bleeding, as clinically significant bleeding. So where many hematologists have come down to on so far is for right now, they're giving routine prophylactic doses of anticoagulation, and they're studying whether intermediate or fully high-dose anticoagulation is warranted. I would say personally, it's probably not going to be warranted in the moderate category. As to whether once you get severe or critically ill, you should be upping the anticoagulation, I think still needs to be proven. I would say prophylactic dose, for sure.
Great,
Does
thank
that answer
you.
the question? Yeah.
Yeah, so could you comment on male gender and the risk of severe COVID-19?
Yeah, that's a great question. So there's a number of different theories. So it is the case that a number of epidemiologic studies have linked severe COVID-19 outcomes to male sex. Some of the theories have to do with behavioral differences, rates of smoking, rates of heavy alcohol use. So there may be, behavioral differences that are accounting for some of the worst outcomes in men. There may be comorbidities alongside heavy alcohol use and smoking come the comorbidities that we know are associated with COVID-19. And then more intriguingly, there may be hormonal effects that also affect receptor levels. And so that's being explored, whether male sex hormones have a differential effect on levels of the receptor. And then finally, Eileen Scully and others have been really pointing out to us for years in the world of HIV that there's immune differences between males and females, both on the innate side, innate immunity, as well as perhaps on the adaptive side. And so whether those are playing a role in COVID-19, I think is still to be determined. So it's probably going to be a mixture of behavioral comorbidities, maybe immunologic and maybe hormonal effects on receptors, but how those all will play out is still to be determined.
Great. A question that comes up a lot in the clinical practice with our patients with HIV asking us questions. Are patients with HIV at a high enough risk for severe COVID that they should be excluded from work that puts them at risk for COVID, like cleaning, hospitals, flight attendants, etc., teachers?
Yeah, I've definitely been asked that same question, and it's a good question. So I answer it in two ways. One is I say that probably HIV in and of itself is probably not putting those people at excess risk of severe complications. That being said, there are other aspects of of their health that may impact. So I have a patient who's got severe heart failure, also has obesity, and I think personally that it's probably those other non-HIV comorbidities that place her at additional risk, more so than her HIV. The second aspect is I very briefly mentioned the congregate setting link. Many of our patients in our COVID series either worked or lived in a congregate setting, and as we know from early days, that's been a particularly vulnerable population. So personally, I don't think the HIV in and of itself confers an excess risk, or at least if it does, it's likely to be very small. I think it's those other risks that are probably going to be determinative. So, yeah.
A question perhaps from our patients with HIV or patients on PrEP who have had COVID and are now clinically resolved. When do you feel it's safe to have intimate relations?
Good question. The latest CDC guidance on this period of infectivity, because this is an area that is just really important, and only now are we getting some data on. So we do know that people with mild or moderate COVID-19, if you try to culture the virus from them, usually after about 7 to 8 days after their symptom onset, the beginning of the symptoms, you can no longer find culturable virus. Now you might find RNA, you might find the genetic material based on a PCR, but that seems to be fragments or dead virus as opposed to culturable virus. And in Asia, they've done contact tracing of people who have persistently positive RNA tests, and they haven't found that those people are infectious. So the CDC just about, in fact, I printed this out, July 22nd, put out a revision around their guidance for isolation and precautions. And they said for mild to moderate disease, people essentially are non-infectious after about, a week to 10 days, basically. If people had severe COVID-19 or are immunocompromised with very immunocompromised, it may be a little bit longer. So that's what I tell my patients in terms of, their infectivity and therefore a risk of intimate contact would be probably about a little over a week or more after symptom onset. You got to make sure their symptoms, at least their fevers, have resolved though. So.
Thank you for that. That's a very concrete recommendation. So one we can put in our toolbox for our discussions with patients. So thank you so much. Another question regarding care of patients with mild COVID symptoms. Is there any reversible obstructive symptoms which albuterol would be helpful? And what are your thoughts about acetaminophen versus ibuprofen for body pain antipyretics?
Yeah, good questions. So we're learning so much more than we know right now about the longer term effects of COVID-19. I think it's safe to say that there are certainly a good proportion of patients, maybe even the majority of patients, who will continue to have symptoms even a couple of months after their COVID-19. As to what the contribution is of lung damage and fibrosis, I think still needs to be determined. I think for people who are having some respiratory symptoms, I think albuterol is a reasonable kind of symptomatic relief, kind of like we do in other post-infectious viral illnesses, influenza being an example. And then the second aspect of that question, antipyretics. So early on, there was some concern about non-steroidal anti-inflammatories, and we were often recommending acetaminophen over NSAIDs. I think right now the data for concern for NSAIDs just hasn't really completely panned out there. So I think what I usually do is I start with acetaminophen for antipyretics, but if that's not sufficient, I have said that people can use NSAIDs. So I don't think it's clear enough to say that you have to absolutely avoid them.
Great. What are your thoughts about someone with HIV with a low CD4 count? Could this be protective against hyperimmune response or that inflammatory response to severe COVID?
Yeah, I've been asked that question, and people have wondered about that. Could having HIV somehow protect you from that overexuberant immune response? It's an interesting theory, and I think we just don't know the answer. I wouldn't feel confident to say that patients are protected. I think that's probably, it would be nice, but I don't think that we have enough information on that. I think basically the same message I give all my patients is, because of the comorbidities and other features, it's just incredibly wise to avoid getting COVID-19. And I don't think it's an interesting biological question, though, that I think people should study, but we don't have the good studies yet.
For those outpatients who don't require hospitalizations, and maybe have mild to moderate COVID. Can you again discuss what your thoughts are about using prednisone? Is that an absolute no-no or something we should consider? And then what about some people's thoughts about using vitamin D or some herbal products?
Yeah, so let's start with prednisone. So if they have another indication for prednisone, say they have asthma, I would probably say, you know, you could continue their steroid. But if they don't have another non-COVID reason to use a steroid, I would avoid it in outpatients. There was it wasn't statistically significant. But there was a trend towards harm in those people who were hospitalized who were not on oxygen. And so if your patient is at home, you know, presumably they're not on oxygen, or at least not on new oxygen. I would be wary, and I wouldn't use prednisone unless they had needed it for something else, not for their COVID-19. Vitamin D, zinc, vitamin C, all of these have been talked about a lot. On the Sunday call, I mentioned that NIH Treatment Guidelines Panel, of which I'm a member, has a really nice, they're trying to keep up with all the things that are being discussed. It's an impossible task, but they have a nice section on the data on zinc as well as on vitamin C. So far, no good data supporting use of either zinc or vitamin C for COVID-19, but I would definitely take a look at that before you talk to your patients, because I think that provides good background on, you know, normal levels of zinc and what we know so far about zinc and vitamin C. So.
Great, excellent. I think we have time for one more quick question. How do you feel about the rapid testing public health strategies to contain COVID?
I think what the participant is alluding to is this idea that maybe if we have somewhat less sensitive tests than PCR, but sensitive enough to do frequently and cheaply, that we can test people regularly, you know, maybe even a couple of times a week, could that really have a public health impact? And I think that it really would. I think what we learned about COVID-19 is that you probably need 1 million or more copies per mil of COVID-19 to be infectious. And the PCR tests that we all rely on really detect down to about 100 copies. Some of the antigen tests, some of the other newer tests that are less sensitive probably tell you if you're contagious. And if they can be made cheaply enough, and if they can be done rapidly enough, then you might be able to test people frequently and then isolate people as the time that they're becoming contagious. And so I do think that's a really valid approach to try to implement. So.
Thank you so much, Dr. Gandhi, for this very timely discussion and lots of very concrete recommendations for us to bring back to our practices. So thank you so much.
My pleasure.